Having discussed the coagulation cascade, let's talk about the bleeding disorders. So these are disorders that basically reduce your ability to coagulate and cause the patient to bleed more. In terms of deficiencies, we have the most common, or one of the most important ones, which is going to be factor 8. Factor 8 deficiency is what's called hemophilia A. And then we also have hemophilia B, and then we have hemophilia C, which are factor 9 and factor 11, respectively. These are all X-linked recessive disorders except hemophilia C is an autosomal recessive disorder. We can also have disorders or deficiency, of factor 13. And if factor 13 is deficient, this reduces the ability of your clot to form, because ultimately clots are formed through fibrin, that is the activated factor 1A, being cross-linked. And factor 13 is the one that cross-links all of this. Now, some drugs that could potentially inhibit the coagulation cascade. If heparin-like molecules from the endothelium can increase the activity of antithrombin 3, heparin, surprisingly enough, does the same. Similarly, we also have our DOACs, which include the 10A inhibitors, which, as you can imagine, would block 10A. This is apixaban, rivaroxaban. You have your thrombin inhibitors, which I'll call trans, but basically they're your dabigatran or argatroban. And of course, you also have your low molecular weight heparin, which is the gold standard anticoagulant that is commonly used in a lot of situations. And the way low molecular weight heparin works, and the reason it's been separated from heparin, is it actually inhibits factor 10A, and it also does inhibit factor 2A to a certain extent, but it directly binds this active factor 10A, blocking it from working. And of course, there's the classic drug Warfarin, and the reason Warfarin is written a little bit separately is because it inhibits a lot of things. First of all, it works by stopping the epoxide reductase enzyme, which is important in activating vitamin K in the liver. So this is going to then cause a deficiency of factors 2, factor 7, factor 9, and factor 10. And also, very importantly, protein C and protein S. So for all of these things that are inhibited by warfarin, let's just go ahead and put little W's on all of them. So there's a W over 2, W over protein C, W over protein S. There's W over factor 7, W over factor 9, and also a little W over factor 10. Finally, there are 3 disorders and 2 drugs that will cause this coagulation cascade and clotting ability to increase, i.e. hypercoagulability, or potentially controlling a bleed. So the 2 drugs are aminocaproic acid, or Amicar, which is the brand name, and tranexamic acid, which are both drugs that inhibit this process of plasminogen being converted to plasmin. And again, the way to remember this is if one has a stroke, TPA is one of the drugs that we administer in order to convert plasminogen to plasmin and basically stop the entire coagulation cascade. While if somebody is bleeding, it's the reverse of this. So again, Amicar and tranexamic acid could be used to do that. Another important, or the 3 disorders that are worth discussing here are again going to be deficiencies. So we have our protein C and to a lesser extent protein S deficiency. And if protein C and protein S are deficient, then they will not be inactivating factor 5 and factor 8 as they would otherwise. So that is one potential way to create a hypercoagulable state. Another sort of corollary for this is warfarin initially is actually that causes hypercoagulability by stopping protein C and protein S. And since these have a lower half-life around 4 hours, if I remember correctly for protein C, this warfarin ends up being prothrombotic for the very short duration after administration. And this is what presents as skin necrosis. And then the last and most important prothrombotic disorder that's relatively benign is factor 5 Leaden. So when one has factor V Leaden issues, what we do is the protein C protein S complex can no longer bind factor V, and therefore it cannot cleave factor V at its normal cleavage site. So effectively, all of these work through protein C and protein S. And similarly, on the other side of our diagram, we have antithrombin 3. So if there's an antithrombin 3 deficiency, that will also cause a hypercoagulable state because, once again, when there's any inappropriate clotting, AT3 is not able to do its job. Now, a key way to remember how to deal with AT3 deficiency, if somebody is clotting and they have an AT3 deficiency, you first present them with a high dose of heparin followed by warfarin. And this is to enhance the activity of what AT3 remains while deficient, and then warfarin in order to keep the patient anticoagulated long term.